Welcome everyone to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner. How you doing?
How you doing?
I'm joined today, as always, by my fascinating co-host.
Very fascinating.
Dr. Jason Martin. He's a board-certified plastic and reconstructive surgeon. Dr. Martin, how you doing?
I'm very board certified and I'm very fascinating.
You're very fascinating.
Yes.
You are. You're super fascinating.
Yeah.
And so are you listeners. And that's what we're doing today. We're
Awesome.
doing listener questions. There's one voicemail, and you know how I love to beg for voicemail, so you will see all of that information down below, all of our social media handles, and also the phone number where you can leave us voicemails, which I don't have out. Let's see. 303-630.
You've only said it like 20 times.
9038.
Yeah.
I know.
How can you remember patient phone numbers by looking at them once, but you can't remember this one? It's like you have...
Yep, selective memory.
Yeah, or you have something wrong with your brain.
Well, it's full of 1980s R&B. Oh, no, don't put that away. I need that.
Right. Okay,
I need that for the next episode. Yeah, my brain is full of 80s movies or movies, lines, and lyrics.
Yes.
So, yeah, that's why.
Yeah, 80s, early 90s.
Yes.
Yep.
So I really appreciate the feedback we get on the podcast. And some of these questions, actually all of these questions I've answered. The ones that came in on YouTube, I've answered directly, but then just some of them were so good, I thought we could expound on them a little bit more. So
this is always our favorite.
It is, because it helps us know what people want to talk about,
Right.
and also what they have questions on still. Like
And they're always good questions.
Yeah, what we didn't cover. So thank you everyone who sent us a question or a voicemail, which we'll get to at the end. I'm super excited about the voicemail. So without further ado, let's jump right into our first question. So this question was on YouTube, and it was from Michelle, and Michelle's in the UK, which I love.
My wife loves the UK. She loves England. She loves Wales. She loves Scotland. She loves Ireland.
When was the last time she was there?
I don't know if she's ever been there.
Oh. So
And every time I talk about my wish list of where I want to go, like I have Japan, I have all these places. She's like, no, we're definitely going to England, to Scotland, to Ireland.
Well, you guys should go Wall Canyon's there. You can hang out with him in Manchester.
Yeah, I know. But, and I agree with her. I can't wait to go there, but I would like to, have some other aspirations too. But we're definitely going to the UK.
Oh,
so I
yeah.
should definitely look up Michelle if she lives over there. When I go, you think Michelle will let me stay with her?
If we had this conversation about stranger danger?
I guess I really don't know Michelle.
Yeah,
Okay.
yeah. The Michelle and Red Rum, you guys are great people, but Dr. Martin is not going to be reaching
I'm
out
not going to be
you.
staying with
No.
him? Okay, sorry.
But thank you. So let's get into Michelle's question. So she said she's doing some research in the UK into having a facelift and upper and lower blepharoplasty, which is an eye lift. I noticed some, albeit a very few, offer surgery with IV sedation and local anesthesia as opposed to general anesthesia. Would you discuss the pros and cons of both IV sedation with local anesthesia and general anesthesia for us, please?
Sure. What does the LA stand for?
Local anesthesia.
Local anesthesia. Okay. So great question. There's three ways to do surgery, at least cosmetic surgery. You can do it with local anesthesia. Actually, there's 4 ways. So local anesthesia alone. You would always use local anesthesia no matter
Let's
what.
hope so.
Yeah.
In a civilized country.
Yeah. Local anesthesia with oral sedation. So a pill that you take, and one of them we give is Halcyon. You could take Valium.
Or just other oral substances like nitrous.
Yeah.
Like something mind altering.
Right. Pain medication, something like that. You could do surgery with local anesthesia and intravenous sedation. That's something through an IV. Or you could do, in all cases I do local anesthesia, but you do local anesthesia with general anesthesia. So, and in most procedures we do that are not huge, you could do those procedures with any one of those options. We can do a facelift with local anesthesia, or we can do a facelift with general anesthesia. But it depends on the person's comfort. And that's really, I think, what it comes down to. Also, if you're working around intricate areas like the eyelid, sometimes you really don't want the patient to move around or be awake. So that's the main thing. Now, for upper eyelids, we do upper eyelids primarily in our office under local anesthesia without even a pill to make you sedated or to relaxed or anything else.
Yeah, because we do need you to be aware enough to not move.
Right.
So we don't want you totally loopy.
Right. So that local anesthesia, it's only about 3 cc's, which is not much on each side. Once you're numb, you won't feel it. And everyone does well, even people that don't like shots.
Yeah. Or people that are claustrophobic. That is the one thing that people who are claustrophobic are sometimes worried about, because, you're awake and your head is covered. You can't open your eyes.
An upper eyelid blepharoplasty or eyelid tuck involves removal of skin and sometimes fat. You can do all that under local anesthesia in every single patient. I'm not saying every single patient would choose to do that, but that is completely standard, and at least in our office, and okay. Lower eyelids, totally different situation. there's two ways to approach the lower eyelids. Amy, how would you describe that, surgically speaking, so people understand, so I don't use big surgeon words?
Well, I'd first say we have a whole episode where we discuss blepharoplasty. So if you really want the details of these surgeries, please do watch that episode. But a lower lid blepharoplasty can either just be external, which is just the skin,
Right.
or internal, which we go kind of inside the lower eyelid to get at some of that fat and the muscle.
Right. And that's the pretty standard way to do it. It's a high-level way to do it. So you remove the fat bags, and you can also remove some external skin and tighten the muscle on the outside. If you only need skin removal and muscle tightening, you could probably just do that with local. But that fat removal on the inside, which is definitely doable with local alone, that's pretty tough.
Yeah, it's not. I would say it is very, very challenging.
And even with local and pills, it can be tough too. It's doable, but tough.
We've never had someone say that they wanted to do it again awake, ever. We don't offer it to patients, and the patients who have done it have said that it was not probably the right decision.
Right. But again, it's doable. Some offices do it as their standard. But we found in our experience that patients can be pretty uncomfortable. And those are the situations where we really get into taking fat out, really deconstructing that lower eyelid. It's better to have at very least IV sedation. And if you're doing IV sedation, then maybe you would consider general anesthesia. The facelift goes through every facet of mini facelift, which is not much, Michelle, or something that's like a full face and neck lift where you're tightening the muscles on the neck, which are called the platysma muscles, where you're elevating the SMAS, which is the deep layer on your face, and doing fat injections and all this kind of stuff. I mean, at that point, it's going to be pretty hard to stay still for 3 to 4 hours.
Stay still, not use the restroom.
Local anesthesia only lasts, its half-life is not long, so you get a couple hours out of it. You can go to longer acting local anesthesia, but then you can't use as much. It gets a lot more complicated. So you have to be a very motivated person to do a full face and neck lift under local anesthesia. It's doable, but you would have to be motivated, and it's not easy. So our general rule of thumb is the things that are quicker and easier we do under local anesthesia. It saves patients money. It actually has less complications, less infection, less other problems that you would get in a hospital setting or a surgery or setting. And then things that are more complicated, combination procedures and longer, we tend to go to at least an IV sedation procedure and many times general anesthesia. The last thing I'll say on this, I'm sorry to keep talking so much, but the last thing I'll say is, are you bored?
Nope.
Okay. I don't believe that. The last thing I'll say, she knows all this stuff. This is what's, but the last thing I'll say on that is that there's not a big difference between deep IV sedation and light general anesthesia. That's where people get all messed up. So if you have a colonoscopy, most likely, and this is true even in England, okay, where you have a different healthcare system, you're probably going to get something like an IV sedative in your IV, right?
Oh, I'm sorry. I thought you were asking the general population out there.
Oh, are they going to respond to me?
Maybe that didn't seem like a question.
Okay.
So yes. Yes.
Anyways, so you would have IV sedation, and that what they use for like a colonoscopy and IV sedation, they use the same thing in general anesthesia. The difference is in deeper general anesthesia procedures, they use inhalational agents, things you breathe in. Those are the agents that have postoperative nausea and vomiting, headache. They make you feel like crap, and when you wake up, you just don't feel like yourself. These IV agents are quick on, quick off. So if you had a cosmetic procedure, which is fairly non-invasive in comparison to other things like going into your stomach area, going into your brain, going into your heart.
Joints.
Yeah, going
Total
into your joints, then you're going to have a lot lower amount of anesthetics. And that's really important to understand.
Yeah, and I think the pros and cons of, IV sedation versus general anesthesia really depend on the type of surgery you're having, like Dr. Martin mentioned, but also on patient comfort is a big part of this when you're doing elective procedures. We're not in this to torture people. And if you as the surgeon are extremely concerned about your patient's comfort because they're not tolerating this procedure well, are they going to get the best surgery possible?
That's a really good point.
Yeah, probably not.
Yeah.
I mean, we've run into this with even awake liposuction cases where a person just can't really tolerate it. Are they going to get the same result that they'd get if they were asleep in the OR? Nope. They're not. Are they still going to get a great result? Well, yeah, because Dr. Martin's a great surgeon, but that probably couldn't be said for all surgeons across all,
Wait, what did you call me? Fantastic at the beginning? I can't remember.
Fascinating.
Now. Fascinating. I'm sorry.
Yeah.
I'm great and fascinating.
You're great and fascinating. So that comes into play as well. So if your surgeon's comfort level is to do a surgery a certain way, I would go with that. These are all very safe. The risks, we have a very old podcast with no video where we talked to Dr. Merrill. I have the video of that, but it's real ghetto. It was on my phone. So it's just audio only, where we talk about the risks of anesthesia in general, and they are extremely low. Like, you're far more likely to be injured on your way to the hospital in a car accident than you are to have any type of complications from general
even
anesthesia.
comparison to general anesthesia, right? Not just IV sedation, which is a lot less risky.
Yeah. So they're really low risk. And that's where I would, if you're fighting surgeons and this is their preference to do these procedures one way or the other, talk to them about why that's their preference. And that's really going to give you your best ideas to what the best option is. Yeah.
And as the person that does the surgeries, I agree with Amy 100%. If the patient's uncomfortable, I have to kind of dial it back a little bit. That's true with liposuction. That would be true in an eyelid procedure. Yeah. And it's a lot better to have carte blanche as the surgeon. Now, is that going to drastically change your outcomes? Maybe not. But if it was me, I would want the best outcomes. And if you're telling me, if you can believe what we're saying, you can do the research yourself, that IV sedation or general anesthesia at a certified place in England, a place that in the United States that has been, at least here it's Quad A and JACO certified places. I'm not sure what it is in England, but whatever that governing body is, you're going to a board certified equivalency in England to that person, then I think you can feel very comfortable that you're going to have a very low risk profile with anesthetics. There is a cost component too, right? And Amy and I are very sensitive to that, but at some point you can't make the decision on cost. If it really comes down to you can't pay an extra $1,000 to have sedation, which you need, then you shouldn't be doing the surgery.
Wait until you have the money.
And wait till you have the money and do it correctly.
Yeah.
There are people, at least in America, who really, their focus is awake surgery. We're actually one of those offices, surprisingly. We do a lot of awake surgery, way more than most people. But there are people that do it even more than we do it. And they do all their facelifts in the office under local anesthesia, all their eyelids in the office under local anesthesia. That's not usual. It's usually a mix. And that mix does come down to patient comfort. No matter what they say, applying or injecting an anesthetic in all these areas in your entirety of your face can be pretty exhausting to people. Most people don't have the strength to tolerate that.
Well, I was just going to bring up the safety component because while that might be the case, I mean, we have certainly seen far more incidences of extremely bad outcomes from that type of mindset. We do surgery in an actual hospital for a reason, and we have never once regretted that.
No.
Ever.
Right. And that's the other part of this. You do something in the office. You're not even in a surgery center, okay, or the equivalent in England, and you don't even know if they have a crash cart there or things that are needed to keep you alive in a serious event. At the least, in a surgery center, they're going to be certified and inspected, and they're going to have
continuous monitoring,
et cetera, et cetera. So we've talked about this before, but lidocaine toxicity is very serious. It can cause seizures. It can cause problems.
Cause your heart to stop.
Like other problems, and in its most severe case, it causes heart block, and you die. And I've seen that personally, not in my patients, but I've read about studies. I've been at places where people have lost their life from lidocaine toxicity that was not perceived or picked up quick enough. So Amy and I always take the path of least resistance for everything that we do for our patients. Safety first, and then we try to find the best way to get this done with the best outcome. And we just don't arbitrarily or dogmatically say this is only in the office or this is only that. We just did a case this week, a body tight, which I absolutely could have done in the office.
Not to the volume you did, though.
Took her to the OR and pushed it 10 or 20% more.
Yeah. Her body weight wouldn't have allowed for even half of that.
Right. And when we were done, the fellow from the university who was with me was like, this is the most incredible case. I'm like, yeah, this is liposuction done super aggressively with the patient asleep.
Yeah.
So it just depends on where you're going. If you want a little eyelid procedure, a little mini face and neck lift, I think that's probably fine to do in the office under local, depending on what your presentation is.
Yeah. Awesome.
Thank you for listening to me.
Thank you, Michelle. That was a great question.
I felt like I was talking too much. You started to make me feel a little bit self-aware. Okay.
Yeah, but there are episodes on all of these surgeries, which I'm sure Michelle's probably found. So
we should probably do another anesthesia episode.
We need to do another anesthesia episode.
I keep asking the anesthesiologist. And now that this thing has grown, I think they're kind of nervous to come in. They're like, I don't want to be seen by thousands of people or whatever.
Put on the spot.
Yeah.
They can sit off camera. All right. Next question is from.
We could just put my bobblehead where they're supposed to sit.
They'd have to get their own.
Yeah.
It wouldn't be fair. Yeah. So our next question was also on YouTube. This was from Jessica G. Best thing to do for hair restoration. My hair has thinned out dramatically, very fine and thin hair. So I started taking Nutrafol supplements, which is a over-the-counter supplement brand that is very big on social media. But saw an ad on your video for red light therapy, which there shouldn't be ads on our videos, I apologize, and have heard of minoxidil for years. What is the most effective method to regrow hair or stop hair thinning? It's a great question.
Yeah. This is not one of my expertises. So
yeah. So I'll kind of go over what I responded and then we can expound on that.
Yeah, I mean, I obviously know more than most, but this is such a great question because there really is not a great answer for this either.
Well, and it's multifaceted,
Yeah,
and that's what
exactly.
I responded. So
Yeah.
the hair loss and hair thinning is you got to first understand like maybe why this is happening now. Is it hereditary or,
Yeah.
have you gone through extreme weight loss? Is that why this is happening?
Stress, your medical conditions. I mean, just hair thinning alone.
Yeah. So understanding your kind of what initiated this to happen, the thin hair or the fine hair might just be your hair's texture, but your hair thinning out, like understanding what kind of was the starting factor. Did you just have a baby? Have you just gone through menopause? So it could be that it's something that will just reverse itself naturally in time. But I would first want to make sure that, you understood like what had caused it. Have you gotten your hormones checked? Are you eating enough protein? Would be my number one question.
Right.
Over-the-counter supplements, I know Nutrafol is a really popular one for women to take. It's also very pricey, I would say, for what you're getting from it. I'm not impressed with the nutritional profile of it over other types of supplements, but I think it's fine. It's not going to be harmful in any way. I would also encourage collagen and biotin supplementation, more so over the Nutrafol. But I do love red light therapy. And there is actually great research, and this is what I told Jessica, on red light therapy, but also on dermal rolling. So there was great studies that were done on young men who had hereditary hair loss. So these are the hardest ones to treat. So they did it up against minoxidil. So they did minoxidil and the dermal rolling. And it was really fascinating because it does actually show promise in helping to regrow hair. All of these things, and I did say this in my response to Jessica, if you stop doing the treatment,
Yep.
the
That's
results
problem.
will go away.
Yeah, besides hair transplantation, there's nothing that's going to have a permanent result without continual treatments, which is kind of frustrating. Minoxidil actually works really well, and we've had multiple patients on that. Have had really good results with maintenance, but you have to maintain it, and that can be frustrating to people.
Yeah, and you have to do it every day.
Yeah.
And there are better forms of it now. It's not so sticky. Like it comes in a foam now. Like there's way better options of delivery. And there's even, like all the online kind of pharmacies, they do like compounded versions that are easier and more tactily, nice to use. But it is something you have to think about. Like, am I going to do this every day for the rest of my life?
Yeah,
Because you have to.
right. I mean, the red light therapies, the light therapies in general, the caps that they have, all those kind of treatments. Anything that stimulates, the regeneration in the skin, you can imagine. We've talked about many of those kind of technologies would probably all work for the scalp. And it's just it's the delivery method. If you take a red light and it's like, 3 feet away from your head, it's not going to do much. But if you can get it closer on there and get the penetration of that energy, especially that wavelength.
Yeah, the caps really do work. I mean, they can be kind of pricey, but they work.
Yeah. I mean, how much are those caps?
The really good ones are going to be probably close to $800 to $1,000. But I mean, you think about it, the cost per use. Yeah, is really good.
I mean, you use that for a year.
Yeah.
Once a week or something.
Absolutely. And way less expensive than other things. The one thing I didn't bring up in my response to Jessica was talking about like stem cell injections or PRP or these other things that are kind of marketed for hair loss. Like, what's your thought on those, Dr. Martin?
I was so trying to avoid talking about that because it gets in that gray area, right? And we try really hard on this podcast specifically to not be in the gray areas, to stick with things that have been approved.
And studied.
Obviously, you can imagine the application of stem cells for hair growth, right? There's a lot of studies going into hair loss and graying of hair right now because it deals with basically these pluripotent stem cells in the hair shaft.
Well, and mitochondrial energy as well.
They change over time. And can you convert those cells back? And actually, there was a study recently that said that those stem cells get stuck. They usually just move around and go different areas. I don't know if it's one hair follicle to another. I'm sure it's just within the hair follicle, but they get stuck and they don't move. And that's kind of what leads to graying hair and hair loss and all this kind of stuff. So there's a lot of research going into regenerative treatments for the body, and the hair is one of those, but it's just not deduced yet. I mean, was just reading a study recently about something else, and it's just, we're so far off from that. The idea, I'm sorry to interrupt, but the idea of disinjecting something right underneath the skin like a stem cell, and all of a sudden snap, everything's better.
Right.
It's so human, like, distortion, because the process of hair growth is complicated. Yeah. One of the reasons why I don't really do it in my office, it takes a lot of stuff. You have to always be on it. I mean, these are treatments that take a long time for hair transplantation. You have to hold people's hands. The hair comes and goes. You have these different stages of hair growth. It gets very complicated, and you need to be super focused on that if you're going to offer that in your office. It's not like this a side thing you offer. So I think that for you, for at least from Amy and I's standpoint, I know she and I both agree, definitely a red light therapy, plus or minus something like minoxidil, and there's other options, would be good, and kind of hold steady until something better comes out.
Yeah, and dermal rolling I would recommend. And more than anything, supplementation is fine, but making sure that you have your hormones balanced and are eating adequate protein. If you can do all of these things, and if you have really unbalanced hormones, like as a woman, you're really going to struggle with hair growth.
I mean, just calorie restriction will make you lose.
Calorie restriction. That's why I said if you've just lost a lot of weight, if you've just had a major hormonal shift, pregnancy, menopause, even perimenopause, like women can start seeing their hair thin because their hormones are really out of whack. So doing all these topical things and even, the light, everything isn't really going to make a big difference if you don't have your diet in check, meaning you're getting adequate protein and you're eating enough and your hormones are balanced. So
this is totally unrelated, but what's the best way to get collagen in your body?
Bone broth.
Okay.
Yeah.
I already knew the answer.
Yep. Bone broth. Oh, bone broth.
Good stuff.
It's my OG.
When I did my colonoscopy, they make you, you can have bone broth, and it's, bone broth to me normally is not that bad because if you warm it up, it has a little soupy taste to it. Like it feels like a soup broth.
Should taste like broth.
Yeah, exactly. When you're prepping for a colonoscopy, it just doesn't taste good. Nothing tastes good.
Well, because it's just going to be exploding out of your body soon. Nothing tastes
good
when you know it's coming right out.
It's not going to go there.
All right, let's take a quick break. Hopefully no ads. No, we're not monetizing the podcast, but occasionally YouTube slips an ad in there. So if there's, feel free to skip it. We're not getting paid for it, so skip the ad.
We should create an ad, pay YouTube for it, and then YouTube would give us the money back. So we could clog up our episodes.
Oh, there are people that do that.
Just an ad like, this is not an ad. We just don't want you to be inundated with an ad that doesn't support us.
Right? Yes. All right, we'll be back. And we're back. All right. Let's keep the questions coming because they're awesome. They're so good. All right. This one is from Irma F. This was also on YouTube.
I like the name Irma.
I know, it's good. And this is kind of a long one, so just bear with me. I'm going to read the whole thing. So I had a facelift 2 weeks ago and very happy with the results, but the top of my scalp is still numb. Not the sides or the back of my head, just the top. My surgeon said it's rare, but it can happen where a nerve can get damaged during the procedure. It usually repairs itself. It can take weeks, months, but it can also be permanent. It's a weird feeling combing my hair.
You didn't put the crying emoji that she had in her. Did she put the crying emoji in there?
She did put the crying emoji.
Oh, I love it. Okay, good.
Yep.
Yeah.
I'm also afraid this numbness might cause hair loss since I've been noticing more hair loss than usual when I wash and comb my hair. Please let me know what you think. I watched your videos on facelift surgery and also learned a lot from them. I did go to a board-certified surgeon whom is well-respected in my city and does excellent work.
So Irma, thank you for going to a board-certified surgeon. Thank you for going to someone who's well-respected in your city and who also does excellent work.
Right, and she's happy with the results of her surgery.
Right.
So the surgery's good.
If we have a great episode on unwanted outcomes, I'm not saying this is one of those situations. I kind of know what's going on here, but you can have unwanted outcomes and still have a good result. Okay. So I'm so happy you're happy. And we fully understand why this would be concerning to you. So I don't think we have the full information here. If she just had a facelift or she had a brow lift, if you do an incision on the frontal hairline, which is the forehead hairline, the way, at least now, that a lot of us are doing brow lifts is we do a subcutaneous or underneath the skin elevation. There's sensory nerves that run up perpendicular to your eyebrows and go up to the top of your scalp. So it sounded like you said back of my head or top of the head?
Just the top.
Yeah, so the top of the head would probably more likely come from those nerves that are going perpendicular to your eyebrows if you're looking on YouTube and going straight up and then branching out. They arborize out from there. So we've definitely had people have numbness, at least on the top and front of their scalp after a brow lift.
And brushing their hair is always what weirds them out.
Right. And maybe a couple, a very small amount, it lasted for a long time. Others, it's only transient. But that can be disconcerting for sure. So there's no literature, there's no experience I've had where they have hair loss that's like somehow related to the numbness. Hair loss,
to nerve damage.
Yeah, hair loss is basically due to like trauma in that area. The reason we do it now, or at least when I do a brow lift, I do the incision on the hairline, is I don't want to do incisions in the hair if I can avoid it, because that can cause alopecia, which is hair loss.
And I'm going to add in really quickly right there, only 2 weeks out from surgery. Surgery is really stressful to your body, and you may not be eating enough or eating quite enough with the additional stress of recovery. So having some hair loss after surgery is not completely unexpected.
Right.
So I would expect the hair loss itself to either be extremely transient or, unrelated to the numbness completely, but just more related just to having surgery in general and just the stress of surgery on your body.
Especially with facelifts, because facelifts, you're working around hair, and sometimes you'll cut the hair because you have to. I actually tape the hair back. When I pull that tape off, sometimes it pulls the hair out. Not in huge bunches, but you get the idea. So
I warn our patients, like the first time you wash your hair after a facelift, it's going to look like you're losing a lot of hair, but it's just hair that we've cut that was kind of trapped.
Right. I try really hard not to cut hair, like really hard. But, if you have super long, thick hair and you're working right around it, sometimes things get...
Well, and sometimes we have to, because the incision is going in the hairline. So you have to clip a little
bit, teeny bit. So,
but it looks dramatic when it's, coming out in the shower the next day.
But she did say that numbness might cause hair loss, and that's not something that I've seen, and it's it's not something we're talking.
She's just asking if it could. Yeah.
And I think Amy makes the point that I was going to make, which she always does first, is that in reality, in the recovery period, it's really hard to judge what's going on. There's so many things that can occur during surgery that can lead to these weird presentations. I mean, just by mere fact of us moving tissues around and putting retractors in, it could push on nerves and cause a neuropraxia. It doesn't mean the nerve is cut, but it just means the nerve is stunned. We get that a lot. Just by boving or cauterizing around it, you may partially injure that nerve, but it's not fully cut. It's rare.
Just tumescing.
Right. Yeah. Just the tumescent itself, when you put the cannula in, can hit the nerve.
And numb it.
And cause a neuropraxia, cause damage, cause a hematoma around it. You can have bleeding around the nerve, which is inflammatory, so the nerve doesn't work well. There's so many different reasons this could occur. We've had people that have numbness on the back of their head just from being under general anesthesia for a long time. We put them on a donut. We make sure that they don't have any pressure there, but still they can have numbness there. So it's hard to judge at 2 weeks. And I think 4 weeks, 6 weeks is where you really start to say, okay, this is what we're dealing with.
I would even say, really, 2 months would be where I would kind of, the acute period of inflammation, kind of let that go down.
Yeah, swelling can do a lot of things.
And put pressure on things. So at 2 weeks, though, it's so hard to judge even, what could be causing something. The great part is, and that's why I told her too, that her surgeon is in communication with her. And I think that is really key. We talked about that in our episode about unanticipated outcomes. The big thing is that you communicate that with your surgeon, go to your follow-up appointments, continue having that conversation.
Yep.
Because even if, in worst case scenario, let's say a nerve, it would be unusual in that part of the head was completely knocked out. There's still a good conversation to be had there. It doesn't mean you just stop talking about it.
Right.
And that I think is, to me, I think that's also the benefit of going to a board certified plastic surgeon. They're going to continue working with you. They're going to hold your hand through this, hopefully. And
yeah, they're going to be professional because our job is to take care of you. Yep. Right. And so your surgeon you went to wants you to have a good outcome, does care. The fact that you've been talking with them is such a net positive. All right. So let's test Nils real quick. If you cut a nerve, Nils, okay, and then you sew it back together, or say it's partially cut. And a nerve is like an electrical wire. Just imagine the ones outside. It has a covering on it, like plastic covering. Obviously, it's not plastic in your body. We know that, right? And then there's stuff on the inside which are axons. And so there's a lot of little axons in there, where it's not just one filament. How on a normal size facial nerve, if you put it back together, how long does it take for it to grow through it? How far will it grow per day? Does it grow a centimeter? Does it grow
per day?
A millimeter? Does it grow a foot? What's your guess?
Oh, it would be a little bit. I would say a millimeter.
That's right. Yeah. So that's what, when they do board tests and stuff like that, it's a millimeter a day. And you'll see, so if her nerve was that specific nerve, which it wasn't, I think this is just swelling and surgery. Yeah. But if it was cut, you would see every day you would have a little bit more improvement if you support your recovery and do everything you need to do. So
you also get used to the numbness a little at the same time, so it kind of balances.
It does.
You do.
And the body is amazing. It will start to find different pathways to have sensation.
To give you that sensation. Yeah, I mean, that's why people have phantom pain in limbs that literally no longer exist. And we see this a lot in patients when we do trauma call who've had traumatic injury to the face. They'll have numbness that's in their teeth. So it makes it weird when they try and eat.
Yeah, that's the infraorbital nerve here. And they'll have the neuropraxia, just like getting punched in the face or a car wreck. And right, Amy, I mean, it takes some months for that to come back. And in almost all cases, it does if the nerve is not completely transected and it was so traumatic it destroyed it. The last thing I want to say about this has nothing to do with it. It's so interesting. I'm sorry. But when the nerve, so you cut your nerve, right? The nerve has an outside sheath and stuff on the inside. When you cut it, it's still active on the good side, which comes from your brain and it comes from the
spinal cord.
Yeah, exactly.
Yeah, the power source.
What it does is it keeps the outside sheath on the distal end, and then it starts to replace it on the inside. Isn't that crazy? So it uses the outside sheath as a conduit.
Yep, to pull itself across.
Right. If you get nerve that's cut, like on both sides, and so a piece of it, all you have to do is sew in a conduit from one end to the other, and then it grows through.
Yep, it'll jump.
Like centimeters, like inches. Yeah. So they do that all the time in reconstructive surgery. Yeah.
So I guess the big question everybody's asking then is like, why do people get paralyzed if you can just sew it back together?
Yeah. Well, okay. Yeah. That's just medicine, right? We can do one little nerve, but if you're talking about a spinal cord, they just haven't figured out how to do that and connect it.
Yeah, it's crazy. The body, I say this all the time on the podcast, but the body is so fascinating.
Yeah.
1,000 sheep.
Irma, I can feel very confident just by reading these couple paragraphs that a lot of your sensations will come back. Maybe not all of it, but a lot of it will. And secondly, that you're doing great. So keep your head up. No reason for crying emojis. You can give the emoji, which I like to do, which is biceps. Pulleys. Give the pulley emoji. I give that to everyone. It's totally not. It's a non sequitur when I do it too. It's like, hey, what are you doing this morning? I'm going out to brunch. Pulley emoji.
You're just flexing. That's what you're just saying.
I just flex all the time.
Yeah, you're just hard flexing on everybody.
I'm getting some gas.
Yep, flexing. You gotta start using the robot flexor.
Picking up the dogs.
Yep. Flexing. All right, Irma. Thank you so much and so glad you're happy with your facelift. That's awesome. We love to hear that. All right. We've got one more written question, and then we have our very exciting voicemail. So this one is from Snowcat, also on YouTube. Can you speak more to scarring in people with darker skin? What is the downtime for a scar revision? So I'll recap what I said, and then we'll let you talk. I said the downtime depends on the extent and the location of the scar revision. Really can go anywhere from being extremely simple, just a couple of days of downtime, to being even more like a surgery. If we're doing a massive scar revision, it might be similar downtime to if we were actually doing the surgery itself. So really depends. Scarring on darker skinned people really depends a lot on the person, and their history of scarring is our best indicator of what to expect moving forward. There are some things that can help with scarring in general in people of all skin tones, and also some things that unfortunately with certain skin types are not super effective. So what's your input, Dr. Martin?
Totally agree. Nils is going to show the scar episode right here. So if you look on our YouTube channel.
Which I think is maybe the episode that this question was on.
Okay. So if you watch that, then that's good. Then you're very knowledgeable. For sure, scar revisions really depend on the location, the extent, and also the severity of the scar. So if it's like over a joint or it's on your face, that can be a lot more complicated than something that's on your torso from a dermatology procedure or something like that. For sure, people with darker skin, and Amy, what's the Fitzpatrick? Like 3 and above. Fitzpatrick 3 and above. Those people have definitely worse scarring outcomes in general or on average than maybe a lighter skinned person. But we have a lot of dark skinned people that heal just fine. Oh my
goodness, heal amazingly
We have dark skinned people that have bad scars that I do a scar revision on, and the scars heal perfectly. So some of this, and we've talked about this before, is the milieu of recovery. It's what's going on afterwards.
Not just the human component.
Right. So if you have had a procedure done, you've had a trauma, maybe you didn't care for it well afterwards. I'm not putting this back on the patient, or there was something medically going on.
Or you were really young.
You didn't keep it out of the sun. You didn't do all the things. So if you're going to do a scar revision, you're going to be hyper vigilant in the recovery phase to make sure this thing heals well. And also, if you start to see it scar bad in the recovery phase, you go to someone like me. We can do steroid injections. We can do verapamil. We can do onlay kind of, what do you call those? Scar
treatments or dermal rolling.
Dermal rolling.
Yep.
You can do RF needling. There's so many different things that you can do to guarantee that you're going to have the best outcome. So I think even if you're dark skin, I'm not sure if Snowcat is, but if you are and you have a scar you don't like, I think if you go to someone reputable, you can be pretty confident it's going to turn out okay. People that definitively keloid, though, that's a totally different story. If you do keloid, then it gets a lot more complicated. But I take care of those people. I still treat keloiding.
Well,
with scars.
There's amazing other options that we do not do for keloid scars. We've actually seen a patient who had terrible keloids from a wrist surgery and had almost like a chemo treatment on the scar, like where it was remarkable. I've never seen such amazing results from a keloid.
One of the other things I've seen up in the mountains is they have a radiation oncologist there. They'll do radiation on keloid scars. And obviously insurance covers this. You're not going to be able to afford out of pocket just to go get some radiation in a scar, but it's very localized radiation. So I think that, just being evaluated by an expert that really understands scarring, and that's going to be a plastic surgeon, board certified.
Or even a dermatologist.
Or a dermatologist. I think you could feel very comfortable that you could have a good scar revision. When it gets into very visible places, the face, the hands.
Yeah, or things that impact movement.
That's where I think you kind of have to go to a plastic surgeon, or if it's the face, an ENT surgeon.
Oculoplastic,
yeah. Somebody that really is facile and surgically talented with that kind of stuff. I think it's important.
Yeah, because a lot of times, a scar revision that was from a traumatic injury or something that was like causing some type of lack of function, you want to make sure that the revision doesn't make that lack of function worse.
Right.
And in most cases, there's ways we talk, do we have one? We talk about that in our scar episode about the Z and W plasties, like how you make a scar that is causing constriction or tightness over a joint better. There's ways that you can do that, but those are definitely
do we get to talk about W plasties?
You can talk about W plasties, yeah.
That's when I totally nerd out, and I look over at you, and you're like, "Oh God, snooze fest."
No, I love talking about scar revisions. Yeah, yeah, it's very cool. So my point is that there are great techniques that even if you have a bad scar or a scar that's causing you pain or lack of mobility, like there are always options to address it.
And that's the last thing I want to say. You brought this up. There's two types of scar revisions. There's aesthetic or cosmetic scar revisions, which sometimes insurance covers, rarely they do, and then there's definitely functional scar revisions, which are over joints. You got scar contracture, limiting movement, pain, all the things, the buzzwords that medical insurances will cover.
Yeah, or from a traumatic injury.
Yeah.
That's not a cosmetic scar. Like if you were a dog bite or a car accident. We have a case like that coming up where a patient had severe scar on their scalp from a car accident. That's going to be covered by insurance. So yeah, it happens. All right. I've been waiting for this. I put the voicemail last just because I was so excited to get one.
Oh, we have an actual voicemail?
We have an actual voicemail. So again, if you want to leave me a voicemail or send me a text.
So you don't get a lot of voicemails. The funny thing about this is going to keep you going for another year.
Yeah.
Like you had almost given up, so I didn't have to hear about it anymore. But like we had this one voicemail.
And I was super excited to get it.
So who gave you the voicemail?
Well, if you would like to leave us a voicemail, again, I'm going to have Nils put the number here, but it's 303-630-9038. You can leave me a voicemail, and I do listen to them and I respond. So, all right. This voicemail, I don't know the name. You did not leave your name, voicemail caller, so that's fine. So I don't know your name, so it's just voicemail.
It's like a mysterious caller.
It is. So here we go.
Hey, Amy and Doctor. Well, one, I just wanted to thank you. I just completed a facelift and followed your vitamin regimen. I believe that was in your last facelift, part 2, for surgery recovery, maximizing your recovery, regarding vitamin supplements. And so I've been on the regimen of zinc, the B vitamins, liposomal curcumin, CoQ10, liposomal vitamin C, glutathione, phosphorus. I had a question for you. So tomorrow will be 2 weeks post-op, and I'm gathering data on the most highly recommended scar surgery cream / silicone, and was hoping to find out what your recommendations were on that. Thanks so much. Take care.
First of all, I love that you did the entire post-op supplementation protocol. Like you got them all.
The second thing I love is you're gathering data. Okay. Yep. I mean, I don't know where you live. Please come in so I can hug you.
Well, because there's a lot.
I love empowered data gathering people.
So with topical scar treatment, I think it's something everybody jumps to this, right? Like that this is some miracle thing that they're going to put on their scars and their scars will be perfect and disappear and that there's some type of magic involved in them. There isn't. I always tell people the greatest healer of scars is time, and no one likes to hear that. Worst case scenario is you start using a scar cream that irritates the area or a scar treatment. And that's why we tend to shy away from, at least in our climate, things like tapes over scars. You don't want to put anything occlusive over a scar that's not fully healed, and that can become an issue with the scar getting kind of macerated. And if you have a scab there and you're putting tape over it, it can get kind of funky and weird. So before you start any scar treatment, please check with your surgeon to make sure that you're cleared to do that. For us, depending on the person, I would say with a facelift, not until at least probably 3 to 4 weeks after surgery, I would say it was okay. And even then, I would say if you want to, but it's probably not really necessary.
Things with a good blood supply tend to heal really well, and the face is one of the most vascular areas of your body.
Yeah,
that's why
and
it bleeds so bad when you cut it.
Yeah.
So I think that scar creams are maybe less needed in the face in general if you're going to a reputable surgeon that does a lot of face and neck lifts.
Yeah, but we do have a great suggestion. All that said,
yeah.
The one we recommend is Biocorneum. It is a physician-only product. It's great because it has sunscreen in it, which we do really like.
Which is what I was going to get to. I think the sun exposure on the face is the main issue. And that's really going to affect your scar formation. The fact that we do the Biocorneum with the SPF in it, what's it, like 50?
It's a 30.
30.
Yep.
So, and then you can apply that, as needed. It's
you should not rely on that for your only sun protection.
It is really, really helpful. The fact that she's doing your entire regimen is also, he's going to put the perioperative supplementation episode. The patient this week that we did a facelift on,
she bought it all too,
was vibing off that episode. And I was laughing because that's like the one episode that I absolutely did not contribute to. Like there was no part of that episode that was dependent on Dr. Martin. I just stood here looking pretty, while Amy waxed poetic. So, just out of curiosity, Amy, honestly, if someone's doing perioperative supplementation, they're already healthy, they go to a board certified plastic surgeon, a really good surgical facility, the person does a great surgery, the surgeon does. How much do you think that supplementation adds to, if you would say, what's the difference? Baseline versus someone who doesn't do that versus that?
I mean, it's so hard to say because bioindividuality in a person's health prior to starting any type of supplement routine, their age.
If you take the entire cohort of all people who've had surgery.
Yeah. I mean, I would say probably 20 to 30%.
So that high, yeah. I was thinking like 10 to 20. But
yeah. But I mean, think about how nutrient deficient most Americans are.
Totally.
I mean, that's why when you say all comers, not just like our patient population might be slightly different because we're doing elective surgery on healthy patients. You take all comers, like all surgeries, like, oh my goodness, could this make a huge impact on people who are nutritionally deficient going into surgery? I mean, even things like just the zinc, the glutathione. I mean, these are things that your body absolutely depletes very rapidly after surgery. The liposomal vitamin C. Vitamin C is necessary. This is where you did comment a lot in that episode for collagen, for wound healing.
Yeah. And the liposomal part of it is because it's more maintainable and it's either easier distributed. So we talked about that too.
Yeah, well, you're not going to break it. You're going to actually get it to where it needs to be. It's not going to just be depleted by your digestive process.
Totally.
So, I think scar creams are great. I would not rely on them to be magic. So I wouldn't go too crazy thinking that like, oh my goodness, this is going to make or break my outcome. It will not. I also like Mederma. For patients who are really insistent on using a scar cream when it's, I don't want them to spend. Biocorneum's expensive. Even Mederma's pricey. I'll just say, just start with Mederma and let's see how you do. Because giving that scar time to heal on its own when somebody has a beautiful scar from a fascinating surgeon.
Very fascinating.
Scar creams are not magic, but they can be helpful.
All the F words, the fabulous, the fascinating.
Yeah.
And facile. I'm very facile.
Very facile. That's one of the things about scar creams that I think is really interesting is that we don't really know why silicone makes scars do what they do.
Yeah, they think that lines up. We talked about in the scar episode, they think it rearranges the collagen because we use the analogy or the example of Lincoln Logs.
Pickup sticks.
I wonder if this patient remembers Lincoln Logs.
Well, she had a facelift, so yes, she does.
We'll see.
She's at least our age. We all remember Lincoln Logs.
I remember Lincoln Logs.
Yeah.
And so if they spill out, they're all disorganized. And supposedly the silicone imparts a charge, helps the collagen get reorganized so it's more parallel and organized. That's the idea, but they really don't know.
They don't really know. But they don't know it does work. I mean, there's clinical data to show that it does help with the redness and the the suppleness of a scar.
We're not telling you to do this, but more than scar cream, especially for a face and neck, I think, and I'm not telling you to do this, I think hyperbaric oxygen would be better. I think red light therapy would be better for inflammation. I think lymphatic massage or things like that would be better. than probably the scar creams because of how vascular the face is, and also those incisions around your hair. So it's hard to get the scar creams in there. So it's, you know, it's not a one-to-one application. And then really just focusing on avoiding the sun. I think that would be the main thing.
You know what? Go ahead. Finish your
please,
thought.
no, please.
Well, what I was going to say is, this goes back to my massage background. Part of what helps any of these topical treatments work, quote unquote, work, is the tactileness of it. You know, there are, I mean,
we already know, man.
yeah. See, Nils knows
So
too.
if there was a best of for
Yeah.
Amy, we could just go through it.
Right.
First thing is tapping and touching. Second thing is walking. Third thing is nutritional supplementation with perfectly sourced supplements.
Properly prepared
And
nutrient
properly
dense.
prepared,
Yep.
yes.
But that tactile component and having someone show you how to actually massage a scar correctly, that's what it does. Like the purpose, so like if you take, I like pickup sticks. I don't do Lincoln Log. I mean, I had Lincoln Logs, but to me, pickup sticks better describes the chaos of a scar. That dermal matrix is just thrown down like mesh, right? It's just chaos, like chaotic mesh. You dump out the pickup sticks, there's just pieces everywhere, fibroblasts.
It's like mulch just thrown
Yeah.
out. It's not raked
Right?
out. It's not even out. It's not, you know, it's
Yeah.
just all sitting there in this bundle of stuff.
And you're trying to get them to line up. So there's
Yeah.
a specific way to massage a scar. Even just touching the scar in general is going to help stimulate blood flow to that scar. It's
Oh,
going
yeah.
to help get those inflammatory factors to do what they need to do and get out. And it's also, like Dr. Martin said, things like hyperbaric are going to help with that too. But then also that, you know, massage can help that scar formation align properly. So I like bio oil and just have people massage it in twice a day because they're touching their scar twice a day.
In the first, was it a week or so, we have people put antibiotic ointment. We do bacitracin. That's the best one, zinc-based bacitracin. And a lot of that is just putting it on there, creating a barrier, a moist environment for the epithelium to grow across so that scar heals.
We actually use a homeopathic silver topical healing gel.
Now we've upgraded ourselves to the silver gel, which I still don't even know where you found that.
Oh, silver ions are awesome for
Yeah.
healing. Creates such a
I
good
don't know where Amy
environment for
finds
healing.
this. They're somewhere on the internet,
Yeah.
like the dark web or
That's
something.
not the dark web. It's medical. It's a medical treatment.
She's
Yeah.
up at nighttime with like these really like thick
Like,
glasses on.
how
like,
can I make a
talking
scar
to people
heal
in
better?
third world countries.
Yes.
But she somehow finds this stuff. But no matter what, you're just applying something that has some moistness to it, has an antimicrobial property to it, and it creates an environment, again, a milieu for the skin to heal together. That's important. At 2 weeks out, you've already had epithelialization. That occurs in the first 48 to 72 hours in most cases, unless you have a problem area. And at that point, you know, applying something is probably just making people feel better, kind of massaging it in, keeping it occlusively covered for the first little bit of time. But, you know, letting the body do what it normally does is probably the best tincture.
That's what I said
Yeah.
at the very beginning. No one wants to hear it, but time.
Yeah.
Like time is going to make your scars fade, flatten, do all the things. Your body is incredible. You're slow variening. You're self-healing. I mean, when you think about tissue recovery and healing, it is fascinating.
Would you say it's time after time?
Time after time. It's the sands of time.
Yeah.
All the time. So
Oh, that throws back.
just like
What?
something through the hourglass.
Days of our lives, I think, yeah.
So are the days of our lives. Like sand through the hourglass.
Yes.
So are the days of our lives. All
Okay.
right. Well, thank you, anonymous voicemailer. I appreciate your voicemail a lot. I wish you the best of luck in your scar healing, recovery. And
I'm not really happy with this voicemailer because now I'm going to have to hear about it for another year.
Please
of you
leave me
waiting for the next
voicemails.
voicemail.
this was a good one. So thank you everyone so much for listening. Again, one more time, if you would like to leave me a voicemail, because I know you do, you can do that at 303-630-9038. If you're shy, if you don't want your voicemail played, I can always just read it. So if you want to hear your voice,
You could
leave
do
me
an
a voicemail.
AI, changed voice. Just type it in and let the AI talk.
Yeah.
Morgan Freeman.
Morgan
Yes.
Freeman. So I appreciate all of you who leave
That's
questions.
awesome. That has to be the most well-known voice there is Morgan Freeman.
So
Use Morgan Freeman's voice. I'm not sure he would be okay with that, but
all of you
I'm
who
not
left
implying.
questions on our YouTube video, I do appreciate it, and I hope that you found our answers helpful. So
Thank you so
we
much.
will see you next time.
See ya.